For all things health and fitness, this is the Army Gymnastics Podcast.
The Army Gymnastics Podcast.
Discover a fitter, healthier you at armygymnastics.com.
Welcome to the Army Gymnastics Podcast. And get ready, because today we're diving deep into something that touches every single one of us: our health and the healthcare we receive. The question we're tackling head on is your doctor helping or hurting? What you need to know.
It's such a vital question.
Right.
It's natural to place immense trust in the individuals who care for our health. I mean, that relationship with our doctors is so important, right?
Absolutely. It's built on hope, on partnership.
Exactly. Partnership and well-being. But, the healthcare landscape is, it's intricate. And it's just wise for you to be informed about how it functions.
Not coming from a place of suspicion, necessarily.
No, not at all. More from a desire to be an active, knowledgeable participant in your own health. That's key.
Okay, let's unpack this then. A good place to start seems like telehealth, given how much it's changed things.
Definitely.
Just a few years ago, before 2020, seeing a doctor virtually was pretty limited, wasn't it?
Oh, very limited. Mostly for people in, say, very rural areas or places designated as health professional shortage areas.
Right, and even then it was often for established Medicare patients, certain types of practitioners only.
That's right. It's quite niche. Then, of course, the COVID-19 public health emergency happened.
Again, everything changed.
The whole landscape just shifted dramatically. A lot of those previous restrictions on telehealth, they were quickly removed.
Which led to this huge boom in availability.
The massive boom.
And the scale of that increase is really something. Medicare telehealth visits, for example. Didn't they jump like 63-fold?
63 times, yeah. From 2019 to 2020.
Wow.
That's an incredible change in just 1 year.
And on one hand, that offered amazing benefits, right? Less travel, better access to specialists maybe far away.
And critically, safety. Getting care safely during a pandemic, huge upsides.
But there's always a but, isn't there?
Well, yes. This rapid expansion, combined with the temporary easing of some regulations, it also created openings, vulnerabilities.
Similar to issues in regular in-person care.
Exactly. Similar challenges, particularly around potential fraud, waste, and abuse. Unfortunately, some bad actors saw these relaxed rules as an opportunity.
An opportunity for what, mainly? Money.
Primarily monetary benefit, yes. And maybe some assumed there'd be less policing, less oversight during the chaos of the PHE.
So what did this actually look like? What kind of fraud started cropping up in telehealth?
Well, we started seeing a lot of questionable coding and billing. One really common one was upcoding.
Upcoding, what's that exactly?
It's when a provider bills for a more complex service or a more expensive service than what was actually provided during the telehealth visit.
Ah, okay. Inflating the service level.
Precisely. Another area was using unreasonable time-based codes.
Like billing for way too much time.
Yeah, billing for excessive time reviewing records maybe, or having these really long virtual sessions that just didn't realistically take that long.
Gotcha. What else?
We also saw issues like billing for services done by interns or trainees, but using the license provider's ID number without the proper approval.
Sneaky.
And using incorrect codes that just plain didn't match the service rendered. Or even blanket billing.
Blanket billing.
Yeah, where basically every patient gets billed for the exact same services, regardless of their specific needs or condition. Just copy-paste billing, almost.
That sounds really inefficient and potentially harmful.
It is, and costly.
Wow.
We even saw billing from specialties that seemed, less suited for telehealth, like anesthesiology being billed for virtual consults sometimes.
Really? Anesthesiology.
It raised flags. And maybe most concerning was billing for medically unnecessary services.
Like what?
Excessive tests, medications, durable medical equipment. DME often ordered without a proper assessment of whether the patient actually needed them.
Okay, that leads into these telefraud schemes we hear about. That sounds more like outright scams.
It often is. Telefraud involves deceptive practices, usually using aggressive telemarketing. They call people up, offering services or products that are unnecessary or sometimes totally fake.
Who are they targeting?
Often vulnerable beneficiaries. They might promise participation in fake research studies, or access to treatments that aren't proven, or supplies like braces, creams, supplements, things people don't actually need.
That's deeply concerning. Is there actual patient harm involved?
Oh, absolutely. There are serious concerns about patient harm and just the basic quality of care. These so-called telehealth visits often have no real medical value.
And doctors can get caught up in this?
Sadly, yes. Some healthcare providers might be recruited, maybe unknowingly at first, into these schemes. They get paid per order they write, or per prescription.
Just for signing off on things. Wow.
Mm-hmm.
And you mentioned durable medical equipment, DME. That seems to be a big area for fraud, often linked to this telefraud.
Very often linked, yes. DME fraud frequently starts with those unsolicited calls or emails. Someone contacts you out of the blue, tries to persuade you to order equipment braces, orthotics are common examples.
Stuff you didn't ask for and might not need at all.
Exactly.
Yeah.
Then the fraudsters bill the health plan, Medicare, whatever, without ever having a proper patient-provider relationship or doing a real assessment of medical need.
And they use those sham telehealth visits to make it look legitimate.
Often, yes. It provides a thin layer of legitimacy. A quick, superficial video call, maybe.
So the patient gets a call, gets talked into needing a back brace, has a 5-minute video chat, and suddenly their insurance is billed hundreds or thousands of dollars.
That's the pattern. And quite often, if any equipment is sent, it's poor quality. Sometimes nothing arrives at all.
And beyond the money, there are other risks.
Definitely. Big concerns about identity fraud and theft when people give their personal and insurance information to these scammers.
Okay, another area you mentioned was prescribing controlled substances via telehealth. Why is that under such scrutiny?
Well, controlled substances, by definition, have potential for abuse and diversion, so prescribing them needs careful oversight. Telehealth adds another layer to that. During the PHE, the DEA did allow some flexibility. Doctors could prescribe certain controlled meds, Schedule II, through via telehealth, without a prior in-person evaluation.
But there were conditions.
Yes. Crucially, it had to be based on sound professional judgment and for a legitimate medical purpose.
Did that create challenges, though, prescribing remotely?
There were challenges, particularly in coordinating some safeguards. For instance, things like urine drug testing are harder to manage remotely.
Sure.
But many existing safeguards stayed put, like pharmacies verifying prescriptions, needing a documented diagnosis, things like that. And we're talking about drugs with recognized potential for misuse, from Schedule II, the highest potential, down to Schedule V.
Okay, so with all these potential pitfalls, the billing issues, telefraud, DME scams, prescribing concerns, what's being done to fight back, how do we mitigate these risks?
There's quite a multi-pronged approach. Payers, insurance companies, Medicare, Medicaid are using increasingly sophisticated tools.
Like technology.
Exactly. Data analytics, AI, machine learning. They use these to detect suspicious billing patterns.
What kind of patterns trigger alarms?
Things like sudden huge spikes in the volume of services billed by one provider, or billing patterns that are way out of line compared to peer statistical outliers, or billing for excessive amounts of time, like we discussed.
So the data can flag anomalies.
Yes, they proactively mine the data, looking for specific billing codes, often linked to fraud, or just unusual practices overall.
Makes sense. What else?
Patient education is absolutely critical. If you know what scams look like, you're much better equipped to spot them and report them.
Empowering the patient. I like that.
And collaboration is key too. Payers, healthcare systems, law enforcement, policymakers, they need to share information and work together.
Breaking down silos.
Right. Many providers also have their own internal prevention programs, ongoing training for investigators. And of course, hotlines and referral systems are vital for reporting suspected fraud, waste, or abuse.
And presumably looking at the actual medical records.
Oh, definitely. Reviewing medical records is still fundamental to verify that the services billed were actually provided and were, in fact, medically necessary.
Okay, let's shift gears a little. We've talked about problems and risks. What about solutions or positive approaches? This idea of patient-centered care, PCC, comes up. What exactly is that?
Patient-centered care, PCC, it's really a philosophy, a model of care that puts you, the patient, right at the center. Your needs, your preferences, your values.
So it's about involving the patient more.
Actively involving you in decisions, yes.
Yeah.
Taking your perspective seriously. It's a shift from just focusing narrowly on the disease to considering your overall well-being, your quality of life.
How does that help, practically speaking?
Well, research shows it can lead to better outcomes. Studies link PCC to patients reporting better physical and mental health.
Interesting.
And it can also increase understanding and sort of buy-in when interventions are necessary. People feel more confident about the treatment plan.
That makes intuitive sense. If you feel heard and involved, you're probably going to feel better about the whole process.
Exactly. And interestingly, patient-centered care might also help reduce unnecessary healthcare use.
How so?
By fostering better communication, closing that information gap that sometimes exists between doctors and patients, it leads to more informed, shared decisions. This can cut down on unnecessary prescriptions, maybe duplicative tests, even some avoidable hospital readmissions.
So a stronger doctor-patient partnership could actually mean more effective care and maybe less costly care, too.
That's the idea. When there's trust and good communication, you're less likely to get tests ordered just because the doctor's uncertain or because the patient feels like something must be done, even if it's not clinically indicated.
This whole idea of informed decisions feels especially relevant for medical screenings, where guidelines can seem, well, all over the place. Mammograms are a classic example.
Oh, definitely. Screening mammography is a perfect example of where conflicting guidelines can cause real confusion for people.
Yeah, you hear different things.
On one hand, you have numerous large studies, randomized controlled trials, showing a significant reduction in breast cancer deaths with screening. Some show, 15–26% reductions, maybe even higher for women screened regularly.
So there's clear evidence of benefit.
There is substantial evidence. Projects like the Breast Cancer Detection Demonstration Project really highlighted mammography's role in finding cancers early. Some long-term data suggests even bigger mortality drops for consistent screeners.
But then there are the counter-arguments, the studies questioning the benefit, pointing out harms.
Right, and those are important points to consider. Issues like false positives, which cause huge anxiety.
Definitely.
Then there's the radiation exposure, though it's low, and the potential for more tests, biopsies after a false positive, and this concept of overdiagnosis.
Overdiagnosis, meaning finding cancers that wouldn't have caused harm anyway.
Exactly. Detecting slow-growing cancers that might never have become clinically significant in a woman's lifetime. Studies like the Canadian trial, or work by Olson and Getcha, fuel debate about the size of the benefit versus these harms.
And changing recommendations don't help the confusion?
Not at all. The lack of one single uniform national guideline in the U.S. adds to it. Should you start at 40, 45, 50? Screen every year, every 2 years.
It depends on risk factors too, right?
Absolutely. Individual risk, age, family history, it all matters. Which is why that conversation with your own doctor discussing your specific risks and benefits is just so critical.
It really loops back to that patient-centered approach, having a doctor you trust to talk through the evidence in your situation.
Precisely. You need that open dialogue to figure out the best strategy for you.
Now, this issue of unnecessary tests and procedures, it goes beyond just screening, doesn't it?
Oh, much further. It's
Yeah.
a huge driver of healthcare costs. Medical waste back in 2018 was estimated to be a massive chunk of healthcare spending.
Wow. And unnecessary tests are a big part of that waste.
A significant contributor, yes. That's why initiatives like the Choose Wisely campaign exist, trying to get doctors and patients talking about whether a test or procedure is really evidence-based and necessary, avoiding things that are unlikely to help.
And it's not just the money, right? There are other costs.
Absolutely. Even simple tests carry some physical risk, however small. But there's also the mental health cost. The anxiety of waiting for results, dealing with false positives.
Which can lead to more tests.
Exactly. A cascade of further, potentially unnecessary interventions. Think about PSA testing for prostate cancer in very elderly men.
Right.
For some older men, the potential harms from diagnosing and treating a very slow-growing cancer might actually outweigh any potential benefit in terms of living longer or better. It's complex.
So again, that trust, that relationship with your doctor is key to navigating this. Avoiding tests just out of anxiety or uncertainty.
It's fundamental.
Yeah.
And sometimes bringing in a specialist can help too. A consultation might give the primary doctor more confidence, reducing the urge to order tests just in case.
Okay, shifting focus slightly to another health topic that's seen some interesting developments. Cervical artery dissection. That sounds serious.
It is serious.
Yeah.
It's a tear in one of the arteries in the neck, and it can lead to stroke, especially in younger people.
Younger people.
Yeah, it's actually one of the more common causes of stroke in people under 50.
And there's been an increase.
A study found hospitalizations for it nearly quintupled over about 15 years, from 2005 to 2019.
Wow, quintupled. Do we know why?
It's not entirely clear. It could be partly due to trauma, like from car accidents, but also maybe smaller injuries, even things like heavy lifting in some cases.
Or maybe just better detection.
That's definitely a possibility. Greater awareness among doctors, better and more accessible imaging technology like CT scans and MRIs might be finding more cases that were previously missed. Or it could be an actual increase in the condition itself. We don't know for sure yet.
But it highlights the need for early detection.
Absolutely. And for more research into prevention and better treatments, it's a significant issue, especially for that younger demographic.
Okay, and one more area with new guidelines, self-collected HPV screening for cervical cancer. This sounds like a big step.
It really is potentially transformative. The FDA approved the first self-collection devices for HPV testing back in May 2024.
And now there are actual guidelines for using them.
Yes, just published February 21st, 2025, the first ever clinical guidelines on how to incorporate self-collection into practice.
So how does it work? You do it at home?
Not quite yet for primary screening. The current guidelines are for self-collection done in a healthcare setting, like a doctor's office or a clinic lab. It offers privacy during the collection itself.
Okay, so you collect the sample yourself, but in the clinic. Then what?
The sample is tested for high-risk HPV. If it's negative, which is the case for about 90% of people, the recommendation is to retest in 3 years.
And if it's positive?
If it's positive, you need follow-up. That usually means standard cervical cytology, like a Pap test, or maybe a newer test called a dual stain test. Depending on those results, you might need a biopsy or a treatment.
Are there different levels of positive results?
Yes. If the test is positive specifically for HPV 16 or 18, which are the highest risk types, the recommendation is to go directly to colposcopy and biopsy.
Okay.
If it's positive for other lower risk types, like 56, 59, or 66, and they do extended genotyping, the guidance might be to repeat the test in 1 year.
What are the main benefits of this self-collection option?
The big hope is increased access and screening rates. It's a great option for people who prefer not to have a speculum exam, or maybe their primary care provider doesn't typically do pelvic exams.
So it removes a barrier for some people.
Exactly. It could also potentially help with clinic backlogs or during provider shortages, make screening more convenient overall.
Are there people who shouldn't use self-collection?
Yes, it's not recommended for everyone. Not for those with symptoms like abnormal bleeding or discharge, people with suppressed immune systems, or anyone who's had recent abnormal HPV or Pap results. They need standard clinical evaluation.
It's still amazing that cervical cancer is so preventable with screening.
It really is. Early detection through screening makes it highly preventable and treatable. Yet thousands of women still die from it each year in the U.S. alone.
And most cases are in women who weren't screened.
The vast majority, yes. Unscreened or underscreened women. So the hope is that offering self-collection makes screening more comfortable, more accessible, gets more people screened, and ultimately helps us move towards eliminating cervical cancer.
That would be incredible. So we've covered a lot today, from the potential pitfalls in telehealth and unnecessary care to the power of patient-centered approaches and new screening options.
It really underscores the need for all of us to be informed and proactive about our health.
Engage in those conversations with your doctor, ask questions, understand your options.
Be an active participant. It's your health journey.
So as you reflect on our discussion today, maybe consider this. How can you become a more informed and engaged participant in your own healthcare journey?
A great question to ponder.
And remember, for expert fitness advice and personalized plans, visit armygymnastics.com, your go-to resource to reach your goals. Start your journey today at armygymnastics.com.
Thanks for listening. For all things health and fitness, subscribe to our newsletter today. Find out more at armygymnastics.com.